going to start the second session for the advanced lung cancer. And we are glad to present Dr. Ahmed Abdelhadi. He's going to speak about the rare oncogenic, no, so this is not, ALK rearranged advanced non-small cell lung cancer.
Good morning, everybody. First of all, I have to thank Professor Reem Ahmed for her kind invitation and organization of this gigantic conference. And now I'll talk about a special entity about non-small cell lung cancer, just 5% of lung cancers. The estimated percentage of lung cancer in Egypt incidence, it lies in the 4th rank, and the mortality rate from lung cancer cases also lies in the 4th rank. As we see, there is a development of research about the molecular deviations in lung cancer. As we all know that the chemotherapy does not satisfy our needs to cure our patients. So we see a lot of mutations and drivers for treatment, like EGFR, ALK, ROS, BRET, MET, and RAF mutation and NTRK. And each one of them and each pathway has its own treatment. In summary, ALK mutation in non-small cell lung cancer, it causes during the fusion of within the chromosome and expression of an oncogenic fusion protein. This protein activates a signaling pathway or cascade in absence of ligand binding ligand, which promotes the tumor growth. This tumor growth is derived via intracellular signaling pathways like the MAPK and PI3K pathways. And when we give the ALK inhibitors, it simply promotes the cancer cell death by restoring the apoptosis and inhibiting tumor cell growth and proliferation. As we know that ALK disease occurs in 5% of patients with advanced non-small cell lung cancer. This 5% usually, we see that the ALK mutation in general in cancer patients, we can see it in lymphomas, non-small cell lung cancer, and glioblastoma multiforme. And in 50% of the patients with anaplastic large cell lymphoma are ALK fusion positive. And in the total non-small lung cancers, it prevails only in 5%. In the MENA region, this 5% is raised to 8.7%. And this is a picture how we are diagnosing ALK translocation under the microscope after immune staining, and is either a few strong cytoplasmic reaction or strong cytoplasmic reaction or mixed. The criteria for these cancer patients that are ALK positive, we usually see that over 80% of the patients are adenocarcinomas, and most of them are non-smokers and young-aged, and there is no sex prevalence between both. So the younger age, median age of 50 years almost, and never or light smokers, adenocarcinoma histology, and usually it presents with high stage with pericardial or pleural effusion, multiple lesions, or CNS metastasis. And now we see that a lot of ALK mutation inhibitors present in the market, starting from crizotinib, ceritinib, alketinib, brigatinib, and lorlatinib, and last is the ensartinib. All of them are ALK mutation inhibitors, and we start with the keynote trials that is supposed to advocate the treatment of each type, of each drug. The profile 1014 randomized trial first compared between the crizotinib and the standard chemotherapy at time, the cisplatin or cisplatin-based chemotherapy or carboplatin. And we see that the progression-free survival was, there is a good difference between the crizotinib arm. It was almost 11 months in comparison to the chemotherapy, which was 7 months only. In addition, that the safety, only the vision disorder and diarrhea was very minimal. So the treatment for ALK of non-small cell lung cancer with crizotinib raised the progression-free survival from 7 months to almost 11 months. The next study is the ASCEND-4, which compared the crizotinib with pemetrexed cisplatin or carboplatin. And the primary endpoint of this study was to assess the progression-free survival assessed by BIRC. And the BIRC is the blind control investigator centrally, so they can buffer the bias got by the investigator during the assessment of the progression during the study. In the ASCEND trial, we gave the pemetrexed maintenance, by the way. And we see that the efficacy, we see the efficacy in crizotinib, the progression-free survival was 16 months, almost double the chemotherapy arm, and the overall response rate almost 72% versus 26%. And this also by an expense of diarrhea, which is higher in crizotinib. And now the second, the first two trials were comparing progression during the treatment was very minimal in alectinib arm, while it was higher in the crizotinib arm. So there was a good control to the CNS metastasis by alectinib rather than the crizotinib. The adverse events in the alectinib arm was much higher in anemia, myalgia, and photosensitivity and hyperbilirubinemia. The CROWN study was investigating lorlatinib versus the crizotinib. At the same time, we are recruiting the metastatic cases, especially the CNS cases, CNS metastatic cases, and the primary endpoint was the progression-free survival. At the same, also the arm of lorlatinib was more higher in progression-free survival, 12 months, 78% versus almost 40% in the crizotinib arm. And the adverse event and the progression-free survival here reached 80% at 12 months, while 35% at 12 months in the crizotinib arm. By subgroup analysis, we see that the lorlatinib, all in the favor of the progression-free survival was in favor of lorlatinib arm. And the intracranial responders in the brain metastases were also almost 80% and 70%, especially the responders and complete responders during treatment. So lorlatinib gave a good response, reaching to complete response in the brain metastases in 70% of cases, while the initial responders was 80%. And time to progression didn't reach in the lorlatinib arm, that all cases which reached complete response didn't recur or progress again after response. The overall survival was comparable in both arms. The adverse events in grade 3 and 4 were higher, mildly higher in lorlatinib arm, and treating discontinuation were comparable between both arms. So the change of the baseline in the global quality of life scores, lorlatinib arm was much higher and better in crizotinib arm. And the CROWN study conclusion that lorlatinib resulted in significantly longer progression-free survival, especially in the brain metastatic cases. Which ALK inhibitor would be preferred? All are the same. While when during comparison between the crizotinib and other lines of ALK inhibitors, we can see that in this table we can see that lorlatinib, which controls more the brain metastases, and the overall response rate was 76%, and the progression-free survival not reached, and the intracranial response rate was higher in 82% of the cases. So the progression-free survival benefit in the ALK inhibitors, we see in this graph, crizotinib reached almost 11 months, xeritinib almost 17 months, alcatinib 34 months, brigatinib 30 months, and ensartinib 25 months. But by the NCCN guidelines, as the longest progression-free survival were the alcatinib, so it is preferred by the decision makers, as it reached almost 35 months of progression-free survival. That is the same. And we see that the intracranial can choose either of the other types. And we see here the mutation status. We see that lorlatinib covers most of the mutation status, and there is some missing coverage in other types of ALK inhibitors. And we see here that G122R, one of the most important mutation of the ALK phosphorylation. So if we have this mutation, we can use the lorlatinib. Other than that, we can use any of the ALK inhibitors. Here is the NCCN guidelines paradigm. We prefer the alcatinib, as we see, because the progression-free survival of alcatinib reached 35 months almost, while during progression after using the alcatinib or one of the ALK inhibitors, we can shift to the other line, either another line of ALK inhibitor, or we can do the mutation to give the ALK G1 to R2 if the mutation happens, so we can take lorlatinib to cover the missing mutation. Thank you.
Thank you, Dr. Ahmed. We'll proceed for Dr. Jessica Miris. She will present an update of immunotherapy for stage 4 lung cancer.
Good morning to all of you. I would like to thank very much the organizers for the kind invitation. I'm really sorry not to be there with all of you. It would have been really an honor and a pleasure to be in your beautiful country, to be there to give this presentation. But unfortunately, this is not possible. But I really hope you are enjoying the meeting, both what you have seen so far and both what will come. My task for today will be to give you an update of immunotherapy for advanced lung cancer. These are my disclosures. This is a beautiful cartoon that Professor Pazares presented at last ESMO a few weeks ago in Paris. It clearly highlights to you all the increasing options we have available in first-line setting, both in the squamous and in the non-squamous histologies, also split by PD-L1 expression status. And the number is really, really remarkable. We will go through some of them, but what we have to bear in mind before describing each trial is that we are still missing a strong predictive biomarker. We have PD-L1, as you saw in the cartoon before, which is what drives our decision-making so far, but still our predictive biomarkers are definitely not strong. We have the tumor mutational burden, the infiltration of T cells either in the tumor or in the macro environment, but none of them is a strong predictive biomarker. What we then use as a selection criteria for our treatment strategy are either patient or tumor criteria or a mixture of them. The reality is definitely a mixture of them. The patient criteria are certainly the ECOG performance status, the smoking status, gender, but definitely also comorbidities, and the more and more also convenience and expectations. We know very well from our daily clinical life that very many patients are reluctant to receive chemotherapy. And this is something that accounts in the treatment decision. For concerning the tumor, PD-L1 status, tumor aggressiveness, tumor burden, and genomics also are criteria for selecting the treatment. Starting from IO monotherapy, this is our standard of care coming from the KEYNOTE-024 trial that has a long follow-up time of 5 years. Pembrolizumab, we know in the high PD-L1 is better than chemotherapy. It prolonged both overall survival and progression-free survival. What is important to see in this curve is certainly the cut point at 5 years. We can see that 32% of patients are alive at 5 years with immunotherapy as a single-agent first-line treatment. And this is something really important that we haven't seen so far in non-oncogene-addicted non-small cell lung cancer. Is pembrolizumab the only agent? Definitely not. In New England 2020, the Empower 110 was published, phase 3 trial, comparing atezolizumab to chemotherapy, and also the anti-PD-L1 agent improved overall survival and progression-free survival in the PD-L1 high expressors. At ESMO a few weeks ago in Paris, the Empower Lung 1 update was presented. We have now the data with the 3-year follow-up time, and both overall survival and progression-free survival were improved by cemiplimab compared to standard chemotherapy, reaching a median overall survival of 23.4 months. What is next? What has still to be done with the IO monotherapy? Certainly the identification of predictive factors. I present you here 2 examples of subset analysis in the Empower Lung 1 according to the PD-L1 expression status. In the Empower Lung 3, a gender difference was seen, but definitely strong predictive factors are needed. Also, strategies to overcome resistance, because chemotherapy is what we do nowadays after IO monotherapy, but targeted tailored treatment would be the dream choice for all of us and for our patients. What about IO plus chemotherapy? In ESMO, Marina Garassino presented the update of the KEYNOTE-189. I remind you, it's a trial comparing pembrolizumab added to standard chemotherapy versus chemotherapy plus placebo for the non-squamous histology, being then chemotherapy, the combination of a platinum plus pemetrexed. The overall survival at 5 years confirms the efficacy with a median overall survival of 22 months for the experimental arm, and most importantly, about 20% of patients alive at 5 years. Again, really remarkable in the non-oncogene addicted non-small cell lung cancer. What about progression-free survival? Also here, very beautiful differentiation in the Kaplan-Meier curves that distance from each other nicely, with about 7.5% being progression-free at 5 years with the combination of pembrolizumab plus chemotherapy. What about activity? Activity is confirmed improved by the addition of pembro to chemotherapy, and we are happy to see that no new safety signal was seen. Is pembrolizumab again the only agent in combination with chemotherapy being presented this year? Certainly not. The Orient 11 trial was presented in the European Lung Cancer Conference. It's a phase 3 trial adding sintilimab to standard chemotherapy, and also this agent improved the efficacy compared to standard chemotherapy, reaching median overall survival of 24.2 months, and the efficacy was seen in all subgroups. Not only non-squamous histology, but also the squamous. Professor Silvia Novello from Torino in Italy presented the update of the KEYNOTE-407 trial. It's a phase 3 trial comparing pembrolizumab added to standard chemotherapy, carboplatin and paclitaxel or nab-paclitaxel versus chemotherapy plus placebo. Also for this combination, we have the confirmation at 5 years of its improved efficacy compared to chemotherapy plus placebo. reaching 18.4% of patients alive at 5 years. Also, progression-free survival, almost 11% of patients being progression-free at 5 years, with an improvement in activity, and also for this combination, new safety signal was identified. What about the combination of chemotherapy with the plus an IO and an anti-CTLA-4? We have the Checkmate 9A. The update was given by Professor Luis Paldares in ASCO this year. The combination confirmed to improve efficacy in terms of overall survival compared to standard chemotherapy, with still a caveat of toxicity being the grade 3 and 4 adverse events, related adverse events reaching 48% compared to 38% of standard chemotherapy. Different strong efforts were made to identify subgroups that had even improved the benefit. What I would like to highlight to you is, for example, age. Younger patients or patients less than 75 years seem to have a stronger benefit compared to the elderly, most likely due also to the toxicity. And the toxicity is also one of the key points for the Poseidon trial. Also, this trial was updated in ESMO this year. You can see here that the adverse events were higher for the combination arm, both in the combination of chemotherapy plus durvalumab and in the combination of durvalumab plus tremelimumab plus chemotherapy. Still, this is an efficacious combination. As you can see, both experimental arms were superior in terms of overall survival compared to standard chemotherapy, but definitely we have to check being this the toxicity rate, which is the subgroup of patients that can better benefit of this type of combinations of two different IOs. What is next for IO plus chemotherapy? Certainly the main point is what to do at progression. I highlight to you here what was done in the Empower Lung 1 trial. In ESMO, also it was some data were shown about the beyond progression part, and in this trial they continued the cemiplimab beyond progression, so adding to the next cycle of chemotherapy. And as you can see here, they reached an overall response rate of 31.3% and median progression-free survival of 6.6 months and a median overall survival of 15.1 months. Certainly these are good data, but more data are needed, and hopefully they will come from the upcoming trials. So to identify the best treatment strategy beyond progression. What about IO plus IO? Not many updates this year. We are still checking in the Checkmate 227. We very well know this trial, but we are definitely going back in analyzing which could be the patient subset that would better benefit of this treatment. And we are trying to analyze better the toxicity profile of this combination. We know that it had more adverse events in general, and even more grade 3 and 4 compared to the chemotherapy. With this analysis, they try to identify which were the most concerned organs, and certainly the hepatic, the pulmonary, and the endocrine were much affected by this combination. Ipilimumab was also attempted to combine with the pembrolizumab, but the combination was not efficacious compared to pembrolizumab alone. So what is next in general in the immunotherapy field? Certainly the timing of immunotherapy stop is one of the key points that we are trying to analyze in both in clinical life and in research. Also, when we think about the possible late immune-related AEs that might occur, Professor Zalkman from France presented in ESMO the IFCT, so an academic French-led trial comparing an early stop at 6 months of immunotherapy versus the continuation until progression. And as you can see from the progression-free survival curves, the stop and go strategy was not worse than the continuation strategy, thus highlighting the possibility that we can further investigate this strategy in other larger and stronger trials. The next question is also what to do in the platinum unfit patient. So the Ipsos trial was presented this year, studying atezolizumab versus IO monotherapy, and atezolizumab was superior to IO with a better safety profile. In general, what is next also concerns the uncovered, but luckily not forgotten other lung cancer populations. So the infections, the COVID, like the HIV, hepatitis, but also COVID-19, the autoimmune disease, brain metastasis, and the reduced performance status. More and more efforts have been done in this fashion regarding consensus and revisions of literature, but larger trials and registries are needed for those settings. So my take-home messages are that increasing options are available in first-line setting, leading to improvements in efficacy for our patients. Strong predictive factors are still missing, and larger efforts are needed in this direction. Second-line treatment is becoming a hot research field, and the understanding of mechanism of resistance is key for the development of new efficacious compound. But certainly networking and collaborations are fundamental for moving forwards in research. And this can only be done with the help of other colleagues around your country or around your continent, and even better, the world. Thank you very much for your attention, and I'm available for questions if there are any.
Thank you, Dr. Jessica, for this is clear and for important subject and difficult situation, actually. I don't know if she's going to receive questions now. We would like to thank you for this is very nice and clear for this important and difficult subject, actually. And I think we are waiting to do what next to do for these kind of patients.
Thank you, Dr. Jessica, for your excellent presentation. I just want to ask you about your take-home message. What is your recommendation? You hear me?
Certainly, my recommendations in general, as you saw, is beyond following what is the current standard of care, is trying to network with other colleagues around to see how they manage their patients currently. This is certainly in the purpose and in the scope of trying to tackle the subgroups for which still open questions are there. How do we handle patients that are rapidly worsening their conditions while we are waiting for the molecular profile, for example? We might have already the immunohistochemistry for PD-L1, but we might be still waiting for EGFR or ALK, and their conditions are worsening. How do we manage these patients? Can we start already a treatment, for example, a chemoimmunotherapy, or should we first start with chemo alone while waiting for the molecular profile? These are certainly realities that we face in our everyday practice, and relying also on the experience of other colleagues in your country or also around the world is really definitely important. And certainly resistance and how to handle these patients in second-line treatment are really important hot topics at the moment.
Do you recommend to start chemotherapy till the result of PDL1?
If we don't have the molecular profile yet and the conditions of the patient are worsening so that we might not be able to treat them with any agent because the conditions are rapidly falling, all guidelines suggest to start a chemotherapy in the meanwhile. This is certainly what we recommend, not only me, but the international guidelines recommend. Of course, the best is to wait for the molecular profile. This is certainly a reality.
Okay, thank you.
You're welcome.
Okay, sorry, are you ready for me to go now?
We will go for next presentation. Dr. Professor Sarah Denson will present bone targeting agent in lung cancer.
Right, thank you very much. So I'm a medical oncologist from Sheffield in the United Kingdom. And we're a centre of excellence for bone oncology. I'm delighted to be talking to you today, and thank you very much for the invitation. These are my disclosures. So the first thing to say is that bone metastases are common in lung cancer, affecting about 40% of our patients. Do they cause clinical problems? Yes, we all see that they cause pain, reduced mobility, impaired quality of life, skeletal-related events and impact on survival. But having said that, the symptoms of bone metastases are actually the first manifestation of lung cancer in only 2.3% of patients. However, our patients are living for longer, and if they now live for 3 to 5 years, they have a 57 to 69% chance of developing skeletal-related events from their bone metastases. So it's a cycle of problems when you've got bone metastases. We know that bone pain causes sleep disorders. Sleep disorders reduce your pain threshold, therefore you feel more bony pain. And the pain is often or sometimes suboptimally managed and should really be a priority when we're treating patients with any tumour type with bone metastases. So skeletal events in lung cancer patients are common, and this is a diagram showing you this. So we know that just under half of patients get a skeletal related event when they've got lung cancer and bone metastases. About 30% of them need radiotherapy to the bone. 20% get a pathological fracture, and then smaller numbers need surgery to the bone, develop spinal cord compression, or develop hypercalcemia of malignancy. Actually, though, if you have breast cancer, you're more likely to develop skeletal-related events with your bone metastases, as the right figure shows. However, if you are a lung cancer patient and you've got bone metastases, you are more likely to go into hospital, and you're more likely to stay for longer in hospital. And it's therefore more likely to cost either the National Health Service or yourself more money. So we know that our patients with lung cancer are living for longer, but we also know that if you've got bone metastases, that this is a very poor prognostic factor. So that if you've got bone metastases, you're likely to live for a shorter time. And if you develop a skeletal event, then you'll probably live for half the time as if you didn't. So what agents are we using? We're using bisphosphonates, rank ligand inhibitors and radiopharmaceuticals, and I'll discuss each of these. And we're using them to treat cancer treatment-induced bone loss, prevent skeletal-related events, manage pain, and treat hypercalcemia of malignancy. So starting with the bisphosphonates, these are agents that have a high affinity for bone. They're rapidly absorbed onto the bone surface. See that there was a 35% reduction in death. And then our elevated NTX levels we know are associated with negative clinical outcomes. So if you've got elevated NTX, as on this side of the line, you're more likely to get skeletal-related events, have progressive
Recording in
disease,
progress.
and die. If we can normalize NTX levels with zoledronic acid, which we can do in the majority of patients, then this is a good thing. So you can see in those patients with non-small cell lung cancer, we can normalize in about 4 times as many cases as we don't using zoledronic acid. And that when we then normalize the NTX levels, we can actually push those patients into a better prognostic category so that they do better from the point of view of bone progression, free survival, but also death as well. Moving on to the rank ligand inhibitor denosumab, which is a fully humanized monoclonal antibody that binds strongly to rank ligand, inhibiting osteoclast formation, function, and survival. There have been 3 large identical randomized trials of zoledronic acid in different tumor types, all of them either randomizing to denosumab with placebo or zoledronic acid with placebo. And looking at the time to first on study skeletal-related event. And these have shown that denosumab is superior for preventing skeletal-related events. The first thing we were worried about when we thought about changing from zoledronic acid to denosumab is how safe that was going to be. So this is a summary of the 3 trials showing that the things that we specifically worry about with these bone-targeting agents, so osteonecrosis of the jaw, occurred in 1.3% of those on zoledronic acid, 1.8% of those on denosumab. Hypocalcemia, which, as you know, when we first started treating patients with these agents, was so profound that some patients died, and we now give calcium supplementation, occurs in 5% with zoledronic acid and 9.6% on denosumab. So looking at the phase 3 trial of zoledronic acid versus denosumab in those which enrolled those with lung cancer, we looked at SREs and could see that denosumab was non-inferior and also that the survival curves overlapped as well. So that was kind of reassuring that it was non-inferior. But then a post-hoc analysis was carried out on the lung cancer patients. So I need to stress this wasn't something that was in the original protocol. So of those patients, 811 of them had lung cancer of various types, and they'd been randomized to the denosumab or the zoledronic acid. So if we look at all of those patients with lung cancer, and you'll appreciate that as we go through these cohorts, there's reducing numbers. If you looked at all of the lung cancer patients, median overall survival was increased by 1.2 months in those on denosumab compared to zoledronic acid. If you then looked at just the non-small cell component of those, then survival was increased by 1.5 months. And if you then looked at the squamous cell part of non-small cell, then survival was increased by over 2 months. So this was encouraging. And on the basis of this, we went on and put the EORTC ETOP Splendor trial together, funded by Amgen. This aimed to randomise 1,000 patients with non-small cell lung cancer stage 4 to either denosumab with their standard of care and then continue denosumab, or to standard of care chemotherapy with best supportive care and then continue as planned. Primary endpoint of this study was overall survival. And we were doing this because we know that RANK is expressed on non-small cell lung cancer cells. We know that in vitro RANK signaling can accelerate tumorigenesis for breast and prostate cancer. Therefore, RANK inhibition can hopefully slow tumorigenesis. NF-kappa B, which is a crucial part of RANK signaling, is involved in lung cancer development, and RANK signaling increases intracellular adhesion molecule 1 expression and MET phosphorylation. So this all enhances your tumour cell migration. And the Scagliotti post-hoc clinical analysis, which I've just shown you, also supported this approach. There was also a systematic review published of 13 randomized control trials with nearly 2,000 lung cancer patients looking at the use of bone-targeted agents in lung cancer. Most of these showed that bone-modifying agents reduced the incidence of skeletal-related events and bone pain, as you'd expect. 3 of them suggested a possible survival advantage. So Splendor was going to answer for us as to whether adding in denosumab would increase survival. Due to the changing landscape whilst we were doing it, we had to stop the trial early, but these were the results that we got with about half of the enrolment, showing that actually overall survival and progression-free survival were not improved by the addition of denosumab. So the current guidelines for treating bone metastases from lung cancer, the NICE guidelines are UK guidelines, and that's telling us that denosumab is a possible treatment for those who would usually consider for a bisphosphonate. The US NCCN guidelines tell us that in patients with non-small cell lung cancer, it looks like denosumab is superior to zoledronic acid, so consider either of those for patients with bone metastases. And the ESMO guidelines recommend either zoledronate or denosumab for patients, as long as they have a life expectancy of over 3 months and clinically significant bone metastases. So are we actually doing what these guidelines tell us? Well, this is a snapshot of prescribing across Europe. 1,600 patients' data was looked at. 66 years of age was the median. Good performance status in about half. And actually, just over 50% were currently receiving bone-targeting agents. And there were differences in different countries. So in the UK, 58% of patients were expected to never receive bone-targeted agents. But the reasons for starting bone-targeted agents were to prevent skeletal-related events and to treat pain. And these were the reasons for not giving the bone-targeted agents. So inappropriate patient profiles, such as short life expectancy, poor benefit-risk ratio, renal
Recording stopped. Recording in progress.
Or that the disease was already being well controlled by the actual anti-tumor treatment. But could we be treating more? You know, this was the take-home message from this particular poster. So I found some more up-to-date data coming out of Italy that looks at how many patients were being treated over a year and looked at how that compared to the type of tumour that they had. And you can see that, as you'd expect, a lot of patients with breast cancer who've got bone metastases were receiving denosumab or zoledronic acid, but also a significant number with lung cancer. So about a third of those that got denosumab for breast cancer were getting it for lung cancer. And in terms of zoledronic acid, lung cancer was the second highest use overall. So I think this is encouraging and hopefully shows we're using more of these agents at the right time. So what next for bone metastases in lung cancer? So we need new drug targets for bone metastases because we can still improve on the results. We need to think about how these agents fit in with immunotherapy and also which agents we should use in which patients and the cost implications. And we also mustn't forget small cell lung cancer and mesothelioma because a lot of this data is in non-small cell lung cancer. So I was specifically asked by the organisers to consider how denosumab and immunotherapy fit together. And we have data that, in fact, giving rank ligand inhibition may improve the efficacy of our immunotherapy. There've been there was a retrospective chart review from China, which showed a non-significant trend towards better response rates and progression-free survival, especially in those with just one bone metastasis and high PD-L1 expression. And encouragingly, adverse events were not increased. There was a cohort study from Italy looking at patients already on nivolumab and considering how those patients did. Those with bone metastases had lower response rates and shorter progression-free survival and overall survival. This particular study didn't give us data about PD-L1, and of course there was no control arm. And then the Denivos trial is a single-arm study of denosumab and nivolumab in second-line non-small cell. It's just 82 patients, but they've demonstrated an overall response rate of 10%, which they feel is comparable to other response rates in this setting. Grade 3 and above adverse events were seen in 20%, which of course is very similar to what we'd see with just immunotherapy on its own. And what is of interest is that 12% of these patients did develop skeletal-related events. So there are reasons that we're adding in these bone-targeted agents in these populations. The other thing of great interest are radionuclides. So the ESMO guidelines did consider a systematic review of using radionuclides in cancer-reported pain relief, but felt that the methodology of this was not robust and that further data were needed in this field. So just looking at what's being done, Strontium 89 is only beneficial in this area when it's combined with zoledronic acid. We ourselves have carried out a study of radium-223 with paclitaxel and treated some patients with lung cancer with that, and that was well tolerated. And there's an ongoing study of radium-223 and pembrolizumab, and we're doing quite a lot of trials with radionuclides and immunotherapy at the moment. And then when you look around, there's other trials going on. So there's a phase 2 study of 188 RE as well in lung cancer patients. So it may be that radionuclides come into this, into the arena for our patients too in the near future. Research continues, so we continue to look for agents to target bone metastases, novel rank ligand inhibitors, MET inhibitors and VEGF inhibitors. But also, even if we can't change the bone metastases and target them, can we treat the pain better? So there are studies with SRC inhibitors, nerve growth factor inhibitors and capsaicin analogues, all trying to help treat pain better in these patients. In the interest of time, I'm not able to go into that in any more detail. So in summary, we know that our lung cancer patients with bone metastases are at risk of skeletal-related events which cause pain, are costly, and ultimately may mean that they live a shorter time. Denosumab and zoledronic acid are known to decrease skeletal-related events and may have effects on survival, but that's not been fully demonstrated yet. We need to continue to evaluate other bone-targeting agents and their effects beyond the bone and on survival, and that work is ongoing. Thank you for listening.
Thank you, Professor. May I ask you, and what's when you start this treatment, as denosumab or others, if the percentage of bone metastasis, how much? I mean, if small, only one bone, or more than 2 bones or 3 bones?
Yeah, so there's not hard and fast rules about that. The argument is that if you've treated the bone metastasis in another way, such as with radiotherapy, then you may hold off on the bone targeting agents at that time. But I guess the flip side to that is that if you've got it in one bone, you're probably going to get it in other bones as well. So our practice is to start sooner rather than later.
You have to add.
Sorry, I can't hear.
Radiotherapy. Are you using radiotherapy if there is still persisting pain on localized area?
Yes.
More questions, please? Amen.
Thanks, Professor Benson, for this comprehensive lecture. My name is Mohammed Imam, medical oncologist from National Cancer Institute. I have 2 questions. The first, we have a data from breast and prostate cancer comparing the zoledronic acid every 1 month to or versus 3 months. Extrapolating from this data, do you recommend using these protocols in lung cancer patients?
Yeah, so whilst the hard and fast data isn't there, I think the rationale is still there that you can do that in many patients. We actually use urinary NTX to guide us with that. So when our patients' NTX is normalized, we move from 1 month to 3 month treatments.
Yeah. Okay. My second question is, in the era of target therapy and immunotherapy, do you recommend adding this bone chelating agent to target therapy like anti-EGFR, anti-ALK?
Yes, we're happy to do that. We've not had any negative events in our practice from doing that. So yes.
Yeah. Okay. Thank you very much.
Thank you.
Thank you very much, Professor.
Okay. Thank you.
Recording stop. Recording in progress.
Okay. About the management of thymic neoplasms, Egyptian NCI experience.
صباح الخير جميعا. First of all, I would like to thank Dr. Reem and the organizing committee to inviting me. We'll go outside lung cancer for a short time. We'll go to discuss the management of thymic neoplasm, the Egyptian National Cancer Institute experience. It was one my publication at 2017 with Dr. Ahmed Fathallah in the Journal of Cancer Therapy. It was one of valued publication at this time, والحمد لله خدنا عليها جايزة النشر الدولي في الجامعة. I'll discuss here cases in this publication and what is its update. As you know all, thymic neoplasm are rare tumors. It is the commonest adult anterior mediastinal mass. Most recent histological classification into 3 groups: thymoma, which is the 50% of cases, thymic carcinoma, 10% of thymic neoplasm, and the neuroendocrine thymic tumor. It may occur in all age groups, with peak 30 to 40 years in patients with myasthenia gravis and 60 to 70 years without myasthenia gravis. There is no sex predilections. The WHO divide pathology into 5 main types, according to which we classify our patient. Type A, thymoma, type AB, type B, which is divided into B1, 2, 3, and type C. What we study in this publication, it was a retrospective study done from January 2008 till 2014. We include 13 patients, 8 men and 5 women. All underwent thymectomy for thymic tumor at National Cancer Institute. Patient demographic characters, surgery, chemotherapy or radiotherapy given, outcome, recurrence, and survival were analyzed. Also stage and tumor size, grade and size, number of mets were analyzed to try to find its effect on survival. Follow-up and statistical analysis of survival was done. This is our objectives. It was to analyze and to report to better understand the clinical pathological features, result of treatment and prognostic factor of these tumors. As I said, we include 13 cases, thymoma and thymic carcinoma. The majority of cases was thymoma. We have 9 cases and 4 cases only of thymic carcinoma. About 46% of thymoma present in stage 1, and the majority of thymic carcinoma present as a stage 4. We have 8 males and 5 females. The mean age of our patient was 47 years, ranging from 21 to 58 years. The mean tumor size was 9.5, ranging from 4.5 to 16 centimeters. The most common symptoms is dyspnea, is the presenting symptoms in 8 cases, and chest pain in 7 cases. No associated myasthenia gravis in all cases reported. We proceed to total thymectomy, aiming for R0 resection for 10 cases. Our criteria to proceed for surgery were well-defined anterior mediastinal mass, lesion within the thymic bed, no lymph node, no elevated tumor markers, and the thymus is not continuous with the thyroid gland through the thyrothymic tract. In non-resectable cases, which are 3 cases, we go for CT-guided fine needle aspiration biopsy for confirmation of diagnosis, then we start neoadjuvant treatment. Surgery was the cornerstone of management of our cases. For resectable tumor, immediate and complete R0 resection was advised and was our aim. In area of uncertain margin, we marked with clips for post-operative radiotherapy. Complete resection is the independent prognostic factor in early and advanced case. R0 resection was achieved in 12 of our cases, about 92% of cases, there is no perioperative death, tracheostomy, or postoperative respiratory failure. Only one patient with R1 resection has, after experienced local recurrence, preoperative chemotherapy or radiotherapy or combination, was individualized and based on the extent of tumor invasion. Neoadjuvant chemotherapy was given for 3 cases, and 2 of them has neoadjuvant concomitant chemo radiation. The chemotherapeutic agent was platinum-based, usually the CAP regimen. Partial response to treatment is assessed radiologically and was seen in all of them. This is the TT of one of our cases. It shows thymic tumor before and after surgery. To the left is before and to the right is after surgery. This is the picture of our intraoperative, one of our intraoperative cases. This is also intraoperative photo. As regards survival and follow-up, we follow patient for 5 years from the start of the study. The mean duration of survival was 22.7 months, ranging from 14 to 36 months. At last follow-up, which was January 2014, 8 patients were alive without recurrence or metastatic disease. Only 1 patient is alive or was alive with local recurrence. 4 patients were dead. We failed to report any association between all variables studied and survival. What happened from January 2014 till December 2021? We go for prospective study to complete this study. We include 12 more cases presented at NCI. Total case from 2008 till December 2021 was 25 cases. I'll show you rapid comparison between 2 groups. Group A or Group 1 from the start of study, and Group 2 from the prospective study from the initial till December 2021. We include in the first group 13 cases. 12 of them are thymoma. In the second group, we include 25 cases. 19 of them are thymoma. The mean age still 40s. It is not a big difference, ranging from 21 to 50 years. In the second group, it ranged from 20 to 60 years, 21. And 3 cases experienced local recurrence. 8 cases were dead. As regards survival, the mean duration of survival of the whole group in the 12-year was 28 months, ranging from 14 to 42 months, compared to 22.7 months of the first group. To conclude this publication, the overall number of patients is not big. We have a very small number, 25 cases in 12 years. Therefore, conclusion based on statistical significance could not be done. Additional multi-center studies are needed to determine predictive of survival and ideal multimodality management. Clinical trial is needed and must be encouraged to define tumor in the era of personalized treatment and target therapy. Long-term follow-up period in all patients is mandatory. Thank you very much for your attendance. And الحقيقة ما قدرتش إن الأونكو إيجيبت يعدي من غير ما نشكر أستاذتنا كلنا ونطلب لها الرحمة، الأستاذة الدكتورة رباب جعفر، ربنا يرحمها، وبطلب من حضراتكم كلنا الدعاء ليها بالرحمة. شكرا جزيلا.
شكرا دكتورة هالة for this presentation.
I have a question for دكتورة هالة. هل كل الثايميك كارسينوما كيسز اتعملت اوبن ثوراسيك سيرجريز، ولا في منها اتعمل في اللاست او في السكند فيز مينيمالي انفيسيف سيرجري، خصوصا ده الايرا الجديده بتاعت الثوراسيك؟
عملت اوبن يا دكتورة.
كلها
اتعملت اوبن.
ما فيش فيهم طيب بالنسبه للار 0 ريسكشن الريشيو ما بين الريلابس او اللي هي الديت كيسز، هل هم died from disease related complications ولا؟
Yes, they died from local recurrence and metastatic disease. Yes.
تمام. وما خدوش راديوثيرابي في الار 0؟
الديتيلز دي يعني الحقيقه مش موجوده قوي لان الريجستري عندنا صعب شويه، بس هم كلهم once they develop recurrence or metastatic disease they die of short time.
اوكي.
الحقيقه احنا كان عندنا بردك استادي في الراديو ثيرابي على نفس الكيسز واولموست الريزلتس يعني كومبارابل يعني الحقيقه.
شكرا.
اوكي. Next speaker will be the Professor Ola Khurshid from the NCI. She's a professor of medical oncology. هي قالت لي علا يا بنتي حرام. محمد انت هتقول؟ جاتش لغايه هناك. We'll change that for the Professor Ola Khurshid. She going to present their oncogenic drivers.
So, good morning. First of all, I want to congratulate and to thank Dr. Mahsin, Dr. Rima Ahmed, and Dr. Rashafan for an exceptional congress as usual. And the reason we chose this topic on rare oncogenic drivers and the targeted therapy is that we have seen the updated guidelines whenever we do in patients, because we do have targets that have impressive overall response rates of almost 80 to 90%, intracranial response rates, and progression-free survival. That is quite impressive. The mesenchymal epithelial transition factor receptor has been shown to be amplified in some patients, but the most common is the exon 14 mutations, and commonly you will see MET-co amplification that is seen as a type of drug resistance when patients are receiving EGFR ALK inhibitors. But for the exon 14 mutation, what happens is there is a skipping mutation where you lose the yellow part, and this leads to impaired receptor degradation, leading to increase in the MET signaling. The incidence of the exon 14 skipping mutation is 3 to 4%, but can be as high as 30% in the sarcomatoid lung cancer. It commonly occurs in older patients. There is a proportion in never smokers, and it is mutually exclusive to other mutations. Now, crizotinib was originally manufactured to target the MET mutation, and you can see overall responses in the range of 32% and the reasonable median progression-free survival of 7.3 months, and has been approved for treatment of the MET exon 14 skip mutation. However, we have better drugs such as capmatinib. In the Geometry 1 study did show overall responses of 41%, and in the treatment naive it was 68%. These results are less still it is effective in patients who do have overexpression or amplification with an overall response rate of 29% and overall response rate of 40%. But you can see that for skipping exon 14 skipping mutation, the results are quite impressive and has been FDA approved. So capmatinib has been approved for the exon 14 skipping mutation in non-small cell lung cancer. Another drug, tepotinib, in the VISION trial, 99 patients have been tested who have MET exon 14 mutation, and overall responses are as high as 44.7%, and the median progression-free survival of 9 months, even in those patients who have received prior platinum-based or immune checkpoint inhibitors. So, just to show you the drugs that we now have for to inhibit the MET for MET exon 14 skipping mutation, crizotinib, response is 32%, capmatinib, tepotinib, and savolitinib, a newer drug, overall responses in the ranges of 60 to 40%, median duration of response of almost 1 year, even those are patients who have received prior treatment. And remember, with the initial chemotherapy, small cell lung cancer patient, and there was an overall response rate of almost 28%,
Recording stopped.
disease control rate of 70%, and a median duration of response that was 5 month. And those were patients who received second, and again, there are impressive results for patients who have received third line treatment with this drug. TDM1, as you all know, has been also tried in patients who had HER2 positive mutant non-small cell lung cancer patients. The overall response rate was 44%, and a median progression-free survival was 5 months. But the most impressive drug that was used in the HER2 positive disease was trastuzumab deruxtecan, and this is monoclonal antibody drug conjugate with a topoisomerase inhibitor that has quite an impressive overall response rate in the Destiny Lung 01 trial. So those are patients who were expressing or HER2 overexpressing or HER2 mutant patients were randomized to post chemotherapy who are refractory to chemotherapy or to standard treatment, were randomized to receive the so they were exposed to the trastuzumab deruxtecan, and you can see an overall response rate of 62%. That was impressive disease control rate of 90%, and a median progression-free survival of 14 months. This is a drug that was given in patients who were refractory or who had relapsed disease. And again, you can see that the results were mainly in patients who had mutation. For those who had overexpression, the results were, if you look at the green side, you're talking about an overall response rate of 20 to 25% compared to the results that you see with the HER2 new mutation. It's in the ranges of 62%. So you'll have much better results if you have a HER2 mutation. And this is just to show you the different anti-HER2 treatments, the TDM1, the neratinib, the pazopanib, and impressive results, as you can see with the trastuzumab deruxtecan, 70% overall response rate. Exon 20 EGFR mutation, this occurs in 9 to 11% of EGFR mutant patients. It is resistant to most EGFR TKI inhibitors. Mobocertinib in platinum pretreated patients who have exon 20 mutation does have an overall response rate that is high in the ranges of 32%, and confirmed disease control in almost 90% of the patients, and a median progression-free survival of 7.3 months. The most impressive drug was amivantamab. This is a drug that targets the exon 20 mutation. It has dual efficacy on the EGFR exon 20 and MET. Initial results in post-treatment chemotherapy patients in the Chrysalis trial did show an overall response rate of 40% and a median progression-free survival of 8 months and overall survival of 23 months. So basically, you no longer test for EGFR, ROS1, and ALK arrangements alone. Now we have other mutations that we need to test for. The BRAF, we now know that we have drugs that do target the BRAF, MET, HER2/neu, also ANDRET and NTRK should be assessed. KRAS is now targetable, yet the question is, should we use these inhibitors in the front line? How do we use them, and when? We need trials that will fine-tune the sequencing of these drugs with chemotherapy, and obviously most of the patients are going to be tested with NGS. And with this, I would like to thank you. And finally, I would like to invite everyone to the National Cancer Institute Congress, which is going to be on the 2nd and 4th of November. And just to tell you that now we have truly reached far in the treatment of non-small cell lung cancer and the oncogenic driver mutation. Now we're talking about 63% oncogenic driver mutations. The more we study and the more we test, I'm sure that we're going to be reaching more. And with this, I would like to thank you and open for all questions.
I think it's a coded lecture. online is Dr. Ola with us or not? Good. Okay. Now, Dr. Muhammad Imam from National Cancer Institute will speak about management of thymic tumors.
First of all, thank you very much for. Do you hear me? First of all, thanks Professor Reem for this kind invitation and great effort for the second edition of this conference. And thanks for all the chairpersons for their attention. My talk today will be about management of the thymic tumors. My name is Muhammad Imam from National Cancer Institute of Egypt. First of all, I would like to dedicate my work, and all of us dedicate our work to the memory of Professor Rabab Kafar. She is a great mentor and she has a great impact on community, oncological community. This is my agenda. First of all, I will discuss the key factors should be considered before treating the patient with thymic tumors. After that, discuss the surgery as upfront and post-operative decision-making, then the systematic therapy, and what about precision medicine approach and immune checkpoint inhibitors. These factors should be considered. First of all, you should diagnose the patients either thymoma or thymic carcinoma, as mentioned by Professor Hala. Thymic tumors have two types, thymic carcinoma, the most aggressive one, and thymoma that subcategorized into thymoma type A, AB, B1, B2, and B3. That is a very important point to differentiate between the thymic squamous cell carcinoma and non-small cell carcinoma, as we have a markers that could be overexpressed in non-small cell lung cancer and present in the thymic carcinoma, including the CD5 and CD117. Second point should be considered the staging system. Now we use the 8th edition of TNMA staging systems versus Mazuka Kuga TNMA staging, as we see, and we have a correlations between those staging and histological subtypes, as we see in this graph. One of the most important prognostic factors in management of the thymic tumors is the completion of the surgical resection. As we see, the survival is improved after complete resection with R0 versus R1 resection. There is approach to direct towards the minimally invasive surgery that increased over the last decade, with improved the surgical outcome, as mentioned by Professor Abdurrahman, compared to the open surgical approach. What about the post-surgical management plan? First of all, this is the recurrence rate of thymoma and thymic carcinoma mentioned in ITMIG retrospective database. And as we see, stage 1, stage 2 recurrence rate reaching 10-year recurrence, 8%. It is very low. But in the thymic carcinoma, reach about 25%. So, depending on the recurrence rate, we have a pattern of this recurrence. Most of the recurrence occurs in the pleural and mediastinal lymph nodes, as we see. According to the ESMO guidelines, all thymic carcinoma receive post-operative chemotherapy and post-operative radiotherapy. But in the thymoma, we have a selection criteria for choosing the post-operative radiotherapy depending on our resection and depending on the histological subtypes, as mentioned in this algorithm. What about the systematic therapy for those patients? We have a different approach. First approach is a primary chemotherapy. It depends or it defines the patient who is localized or early tumors, and another one is exclusive chemotherapy. It relates to the palliative chemotherapy in the metastatic and more advanced stage, and third type is systematic therapy for recurrence. So, first of all, exclusive chemotherapy. We have a case, 27 years old male patient complaining with chest pain and no myasthenia gravis, autoimmune disease. In MDT discussions, the surgery is not sure for this patient, so biopsy was taken and showed thymoma type 3. What about the type of the treatment? Regarding the historical data, we have a clinical phase 2 trials that showed improvement of the survival and response rate depending on many drugs, including anthracycline-based chemotherapy. And also, we have a rhythmic data. And this rhythmic data showed use of a CAP regimen, anthracycline-based, reaching up to 76% and only paclitaxel carboplatin in 8%. When we check the response rate of those patients, we reached about 77% regressive disease in those patients that used anthracycline-based regimen. Another case, this case, when received the new adjuvant chemotherapy, as we see, showed a regressive disease. What is the next? According to the guidelines, if it is operable and surgically resectable, so you should go for surgery. If the patient is if this case is unresectable, so we could refer for radiotherapy plus or minus chemotherapy. And as we know, we have a limited data in the literatures, and there is no consensus about the concurrent chemoradiotherapy. We have two types, either sequential approach and reaching 5-year progression-free survival 54%, and 5-year overall survival 53%. And this is the concurrent approach that using cisplatin etoposide concurrent with platinum-based chemotherapy for unresectable cases. What about the exclusive chemotherapy? I mean systematic treatment for palliative care. This patient, 67 years old male patient with low back pain and hypercalcemia, and biopsy showed thymic carcinoma with those markers, and it is an advanced stage. Also, regarding to the histological data, depending on the phase 2 trials, showed most of the regimen used either platinum-based and anthracycline. And when we check the rhythmic data, we notice that a little difference between the chemotherapy used in the localized or early stages versus in the systematic stage. As we see, CAP regimen anthracycline-based reach about 66%, but paclitaxel carboplatin increased, reaching 20% compared to 8% in the early stage. And this is notice that there is a tumor heterogeneity in the advanced stage versus the tumor nature in the early stage. We have about 1/3 of the patient showed regressive disease, and another 1/3 of the patient showed a stationary course different from the early stage. So the questions: how can you use? Do you recommend anthracycline-based or not? Depending on the data, anthracycline is very effective in thymoma, but in the thymic carcinoma, we don't have a significant difference, so you could use platinum-based chemotherapy. What about the recurrence rate? We have a different recurrence, and we have a different target treatment and different combination, especially the platinum-based like paclitaxel carboplatin. And we could re-challenge with CAP regimen, including anthracycline, and taking in consideration the cumulative dose of anthracycles. Also, we have increase in the use of the target therapy like vascular endothelial growth factor receptor inhibitors. And these two trials that showed use of the sunitinib in the patient who refractory to the chemotherapy in the thymic carcinoma and the thymic tumor with a good response rate and disease control, and another trial that showed rule of everolimus in the patient with thymoma and thymic tumor. What about precision medicine? Unfortunately, there is no genetic mutation or driver genetic mutation that could be targetable in this patient. But regarding this integrating genomic landscape, we have a different pattern of genomic mutations. We are trying to select these mutations to treat those patients. Also, we should differentiate between the thymic carcinoma and other type of the sarcoma, especially SMARC inactivated thymic tumors, and also differentiate it from the not midline carcinoma in the thymic tumors. This is the mutation that present in different tumors according to genetic alteration and next generation sequencing, and we are trying to target this mutation. One of these mutations is the KIT inhibitors for c-KIT mutations in thymic tumors, and showed some sort of the response rate. And there is a preclinical data using the PI3K inhibitors for patients with PI3K mutation, and showed good response rate, and also showed improved progression-free survival compared to the standard of the care. And we are trying to target like mesothelin inhibition that present also in the mesothelioma patients by another targets like XPO1 inhibition that used for that could be targeted by selinexor in the trials, and showed a preclinical data, and we are waiting for more large data. What about the use of immune checkpoint inhibitors for those patients? As we see, those tumors have a low mutational burdens, but in contrast, it have a more expressions of the PD-L1 burdens due to the presence of the tumor lymphocytes in thymic or the thymic tumor. Also, the patient with thymic tumors mostly associated with autoimmune disease like myasthenia gravis, pure red cell aplasia, or hypogammaglobulinemia, and should be considered in management plan for those patients. We have two different mechanisms for autoimmune disease. It depends on the tumor. In thymoma, it has a loss of AIRE antigens, that loss of thymic or immunity selections in the thymoma, and lead to autoimmune disease. And in thymic carcinoma, we have a shared antigens between the tumors and between the normal tissue, lead to autoimmune resection. Also, we have some sort of patient that have autoimmune disease leading to death from the autoimmune disease, not from the disease, and should be considered in our approach. One of the most important trials and observation, sunitinib used in some patients with refractory to another type, but this target therapy could exacerbate the autoimmune disease of those patients, and so should be taken in considerations. This is one of the trials that showed the use of the pembrolizumab and associated with grade 3 and grade 4 autoimmune disease like cutaneous and gastrointestinal tumors. So it is very risky to use those immune therapy, especially in thymoma rather than the thymic carcinoma. And we have now a trial using the nivolumab for thymic tumors, but it is still ongoing. And thank you very much for your kind attention.
Thanks, Dr. Muhammad, for that interesting talk. Any discussion? Any question?
وفي الثايميك تيومرز يعني our main problem two issues بالنسبة للسيرجري working أو operating in a patient with myasthenia gravis زي ما أنت قلت، والسكند ايشو الثايميك كارسينوما، لأن الثايميك كارسينوما ممكن تلاقي التيومر very small 3 سنتيمتر تيومر و very invasive.
Yes.
يعني في patients invading المايوكارديوم والتيومر not more than 3. فدول very important issues. الايشو المهم الثالث اللي هم البيشنتس with metastatic thymoma. البيشنتس دول should be properly studied في multidisciplinary team، لان هم they can get maximum benefit، بالذات لو في pleural mets ان هم يتعمل لهم total pleurectomy مع intrapleural hyperthermic chemotherapy. واحنا عندنا some group of patients surviving now more than 5 years after hyperthermia, intrapleural hyperthermic chemotherapy. You have to give a great effort to operate in those patients.
As we see, Professor Abdurrahman, in this pattern of recurrence, mostly in the pleura. So do you recommend always doing surgery for these patients followed by a high-tech or hyperthermic chemotherapy, especially in the pleura? Yes, no problem. Thank you.
Any question else? Thank you, Dr. Muhammad.
Thank you very much.
Thank you very much for your attendance, and we'll go for a coffee break. Okay, thank you.